this lady was found, she lives in an independent living facility, and her neighbor heard a crash on the floor or on the wall or something, and went over and knocked on the door to check and see if she was okay, and nobody answered the door, so the neighbor called 911, and rescue got there and found the lady lying in the middle of her floor, unconscious, and they popped in an IV and loaded her up and put her on the monitor, and she's actually got pads on and the whole bit. She's here in your emergency department, and here she is.
Okay. Go?
Yep, go.
Ma'am, can you hear me? Can you hear me? Do we have her on the monitor? It looks like her saturation signal is low enough that we're not getting a reading. Which, can you start some, maybe get her, wait, hold on, I'm going to take a pulse. Okay, don't feel pulse there. Kristen, can you start to feel a pulse down there? Okay, we've got pulse.
I don't know if I feel it.
I don't know if I feel pulse. Okay, start CPR. Mush, can you get her bag, please? And we need to get her on the monitor over here. So in 2 minutes, we're going to look at the rhythm.
She's already on the monitor, and 2 minutes has passed.
Okay, great. Hold compressions, please. Check for a pulse down there. We're looking at the monitor. This looks like VTAC or VFib to me.
I don't have a pulse.
Okay, so we're gonna, can you charge the, yeah, that thing, and can you resume compressions
How
while
many
this charges,
joules
please?
would you like
200
it?
joules, please.
And do you want synchronized or unsynchronized?
Unsynchronized.
Okay.
Keep bagging every 6 seconds, please. Okay, stand clear. Administer shock.
Shock
Okay, we still don't have a rhythm. Keep going with compressions and ventilations. Can we get 1 milligram of epi, please? Which is at 36.1.
1 milligram of epi.
Thank you. All right, in 2 minutes, we're going to do another pulse check and rhythm check.
2 minutes has passed.
Okay, so hold compressions. You can keep ventilating, Mush. We still don't have, okay, so charge the EKG, go back to compressions, please.
How many joules?
200. Okay, everybody clear? Administer shock. Okay. All right, keep going with compressions. We should keep ventilating. Can we get 1 amp of amiodarone, please?
Amiodarone does not come in amps, actually.
Okay.
It comes in vials.
300 milligrams of amiodarone.
So that would be here. So 300 milligrams is 2 vials of amiodarone.
Okay,
300 milligrams of amiodarone.
thank you. Okay, in another 2 minutes, we're going to do another pulse check, and
that time has passed.
okay, Ben, can you check for a pulse, please? You can.
I don't feel pulse.
Okay, you can start charging.
How many joules?
Sorry, 200. Okay. Oops, administer shock. Everybody clear? All right, go back to CPR and keep bagging. And can we get another amp of epi, please?
Yes.
And 2 minutes has, 2 to 5 minutes has passed after
Okay.
that epi.
We're gonna do another pulse check now. Ben, can you do a pulse check? And let's keep bagging. It still looks unorganized to me.
No pulse.
No pulse. Okay, let's charge the EKG, 200 joules. Let's keep ventilating, keep doing compressions while this charges, please. Everybody clear? Okay, keep going with CPR and ventilating, please. Another amp of epi, and depending on how long it's been, more amiodarone.
How much more amiodarone?
We would go up, but it would be, I'm going to go with 450, which is the best of my memory of 300 plus
Okay.
150.
Okay. So
50.
and time has passed.
Okay, so we're going to do a pulse check, then stop compressions, get a check for a pulse.
Oh yeah, and then Okay.
All right, we still don't have anything good here, so keep going with compressions. Charge this mush keep ventilating. 200 joules, please. Everybody clear? Youngster shock. Okay, go back to compressions, ventilation. All right, is there any treatable cause of this that we should be like treating right now that we can think of? And if I had brains to brainstorm with, but it would, if we're serious about doing, how old is this lady?
Oh, we're not sure, but she's looks to be in her late 70s to early 80s.
And we've been doing CPR for
Probably about 30
minutes.
or so.
Okay, so I would think about like, is this time to call it? Should we send some labs to like see what she looks like? Should we get a troponin? She hasn't had ROSC, so we can't get an EKG. Yeah.
Okay.
Okay.
So no other thoughts on running the code per se. You
In terms,
besides those things, you at this point you would start thinking about other stuff.
yes.
Okay.
I mean, I might have done that earlier
Okay.
even, but
Good. Okay, let's call the scenario.
okay.
So now we're going to focus on what you did, not because there was anything wrong with it, but because that is what this is about. I think you did an amazing job. As fourth-year medical students go, you really nailed a bunch of stuff, which is great. So there are a few things I want to talk about. One is joules. So the machine goes up to 360 joules. And the number of joules that you can shock the ventricle with, sort of classically number of joules that you can shock the ventricle with, is between 200 and 360. So you have the option of starting at 200 and escalating, or starting at 360 and staying at 360. What you don't have the option to do is start below 360 and not escalate with each successive shock. So the definition of insanity is doing the same thing over and over and expecting a different result, right? So if you're not going to start at 360, you need to go up every time. So usually if you're going up, it's 200, 300, 360. Now I'm all about decreasing RAM personally. The other thing I want to say is just ACLS, American Heart Association, changes the algorithm every couple of years. Okay? They change things in the algorithm every 2 years-ish. What does that say to you?
That we don't really know.
Right, that it doesn't really matter. We don't know, whatever. So the stuff that they change is stuff like, do you start at 200 and escalate to 360, or do you start at 360 and stay at 360, or, you know, stuff like that. Like at times they've said start at 200 and escalate to 360, and then at times they've said start at 360, stay at 360. At times they've said it's your choice. So to me, forget about that per se, what the current guidelines are, and decide what you're going to do. Now I, as I said, am all about decreasing RAM and internal RAM, storage space. And I'm all about not trying to remember numbers in the middle of a stressful situation. This is a dead lady, right? Who's it going to hurt if you start at 360 and stay at 360? Like, she's dead. It's not like you're hurting her. You might as well. The beauty of starting at 360 and staying at 360 is that you don't even have to remember the number, right? You can just say, crank it to the max. Like, I got this. Crank it up all the way up. And you look like you know what you're doing. You're right. And you have no knowledge of what that number might be. And that's okay, because you're still right. So, again, this is kind of like ACLS for idiots, but the fact of the matter is that it doesn't matter if you're at the top, and if you can't remember that number, it doesn't matter, because you're doing the right thing. The same holds true for do you do a pulse check between, this, that, or the other thing, and how often, how many pulse checks do you do, and do you do CPR between your, between your shocks? How many shocks do you deliver at the beginning? Some years they say just 1 shock, and some years they say 3 shocks, and some years they say 2 stacked shocks at the beginning, like before you start the whole thing. And sometimes you're supposed to check a pulse in between those shocks and do CPR in between them, and sometimes you're just supposed to shock, shock, shock. And so they change stuff like that all the time. So the little minor details, forget about it, because they change it all the time. The idea that is important is that you want to do as much CPR, high quality CPR, as you can do, and you want to check a pulse as often as you need to, okay? To be sure you're doing the right thing. Pulse and rhythm. So, it's important when you're doing a pulse and rhythm check to be sure that CPR is held, right? Because you can't see what the underlying rhythm is if CPR is going on, and you don't know if they have an inherent pulse or if it's a CPR pulse. So, CPR has to be held in order to check pulse and rhythm. So you want to be checking your pulse and rhythm at a time that makes sense to you, that there would be a change. So when you deliver a shock, do you expect a change immediately, or do you expect that change to be a couple minutes down the line?
Immediately.
Immediately, right? You deliver the shock, they're either better or they're not, right? So your hands are off for the shock, right? Your hands are off, everybody's clear, you deliver the shock. You can immediately say the patient remains pulseless and they remain in V-fib, continue CPR, right? That's your pulse check, because that's when the intervention is going to have an effect. When you give a drug, do you expect an immediate result, or do you expect a delayed result? Delayed, right? It has to go through the IV up to the heart, circulate around, do its thing on the beta receptors, all of that stuff, right? So the reason we say a couple of minutes of circulation is because that's the amount of time that it takes. So you do your CPR for a few minutes, you've given your epi or whatever, you do your CPR for a couple of minutes and you say hold CPR, you check a pulse and rhythm, right? Remains the same. Now it's time for the next shock. So you just check to make sure that the patient still needs to be shocked. You say continue CPR, charge the thing, right? They charge it up. Shock delivered, check the pulse, rhythm, and then you can order the next drug, because if the shock didn't work, the shock didn't work, and nothing new is going to happen 2 minutes down the line, right? You can do CPR, continue CPR, but as soon as the shock is over, if it did not have an effect, you can do the next drug, right? And you can give epi every 2 to 5 minutes ad nauseum. There is no evidence that more epi has better outcomes. In fact, the more epi that is given, the worse the outcomes are. Probably because the more epi you give, the longer time the code has been going on, and the longer time the code has been going on, the worse outcomes there are. So, let's see. So, the very first thing that we do when we find somebody in V-fib or pulseless VTAC, if you have the machine, is shock. CPR doesn't matter, airway doesn't matter, none of that matters. The thing that's going to get them better is a shock. If it's, if that's the thing that's likely to. Now, having said that, if you don't have the machine in the room and they're not already hooked up to the pads, by all means start CPR and start bagging or intubate or whatever. But if you have access to the machine and they're hooked to the pads and ready to go, just charge it and go. That once you recognize that it's V-fib or pulseless VTAC. So electricity is like when you get the blue screen of death and the circling ball on your computer, right? You know what I'm talking about. What do you do?
Unplug the thing.
You unplug the thing, or you turn it off and turn it back on, right? You reset the electricity. And that's what shocking does, is it's doing exactly what you do when your phone stops working, and just turn it off and turn it back on, right? And so we're like trying to just be like, okay, let's just reset the electricity of this thing and see what happens. Most of the time that works in your phone or computer. Not necessarily, but it is the thing that is most likely to work of all of this stuff, if this is going to work. Now, if it doesn't work on your computer, the very next thing you do after you've turned it off and turned it back on is like hit the computer or jiggle the cord. Any of you done that? Yeah, you know you have. Right? So, epi is like hitting the computer, right? Jiggling it. Hey, wake up. Let's go. Right? So what does epi do in the cardiovascular system?
Vasoconstricts.
Vasoconstricts,
Increases heart rate.
chronotrope, fancy words.
Inotrope?
Inotrope, yes, very good. So it's a very potent, in fact, the most potent vasoconstrictor, chronotrope, and inotrope that we have, right? It is not a precursor, it is the actual thing, right? So we're giving epi and we're saying, hey, wake up. It also bronchodilates, by the way, but we're not using that here. So epi is a wake up, right? So we've now turned the computer off and on. We've gone wake up. That doesn't work. The next thing after we've jiggled the cord and hit the computer and turned it off and on, and our computer's still not working, is what do?
Get a new one.
Call ComIS, right? You do, right? You take your computer to ComIS and you say, there's an underlying problem that needs to be fixed that I don't know how to fix, right? So so we've turned the computer off and on, we've gone like this, but there's an underlying problem that needs to be fixed that we haven't addressed. Did we say anything about epi being an antiarrhythmic? No. Epi's not an antiarrhythmic. In fact, it's a proarrhythmic, right? Because it gets your system all jigged up. So the underlying problem is VFib, right? VFib is an arrhythmia. So let's work with antiarrhythmics. And you immediately went to amiodarone. And I'm going to tell you that I would say half of the medical students I see, shock, epi, shock, epi, shock, and never even go to an antiarrhythmic. So lots of people forget the antiarrhythmic. Anybody in here would have not known to go to amiodarone? Or everybody had that down. And then how did you remember how much amiodarone to give?
I'm not sure. I just saw a code where we used it. And
Okay, maybe
that might have helped.
That might have
and
helped.
I worked through the online
Module
things.
Okay. So you've had a recent exposure to how much to give. Maybe you'll remember that for life because of the recent exposure. Maybe you won't. Amiodarone doesn't come in AMS, which is a little bit problematic. You gave the right dose the first time, which is interesting because a lot of people, if they go to amiodarone, then they don't know the dose. And the dose isn't one bottle. Like I told you, most stuff is packaged in the right amount for your average adult. And here I said, when I said you said 300, I said that's 2 bottles. And a lot of times when you said, people will be like, oh no, I just want 1 bottle. Right? So, did everybody know the dose of amiodarone? Everybody knew the dose. You guys are way too smart. So
Everyone going into EM in here.
so I will tell you a little story, part of which is true and part of which is made up. And the goal of this story is to A, make you cynical about Big Pharma, and B, help you remember the doses. So here is the true part of the story. The data upon which we are giving amiodarone as the first-line antiarrhythmic in pulseless VT-VF, this scenario, is the following. Amiodarone works better than placebo at converting pulseless ventricular rhythms to a pulsed rhythm. Better than placebo. Better than placebo. Now, you did not, when you finished with amiodarone, you didn't have something else to turn to. But before amiodarone was a thing, there were other drugs on the algorithm, other antiarrhythmics, believe it or not, on the algorithm that were not expensive and were generic things that used to be first line on that algorithm. There is no data upon how amiodarone compares to those other drugs. This is true. Now comes the dramatization that I created in my head about what happened in the big pharma lab. So they had this drug called amiodarone, and they said that they knew that this drug was better at converting pulsed ventricular rhythms to sinus rhythm than the next drug on the algorithm, or than the drug that was previously on the algorithm, at a dose of 150 milligrams, which is why it was FDA approved and packaged at a dose of 150 milligrams. So this is true too. So here's my guess about what happened in that lab. They're like, ooh, we have this drug and it might be better than the other drug, right? The other drug, do you guys know what the other drug was? The next drug on the ad? Lidocaine, exactly. So this drug is shown to be better than lidocaine at converting pulsed ventricular rhythms to sinus. So the people that made this drug said, ooh, if we can get this into the ambulances as the first-line drug for, first-line antiarrhythmic for pulseless rhythms, we're going to sell a lot of the drug. I'm making this up. So they said, okay, well, let's take this 150 milligrams and try it against lidocaine. Didn't work. You know they did this, right? There is no reason to publish data that says it's better than placebo unless that's the best you can do, right?
Right.
So they tried it. It didn't work. They're like, ooh, oh, that's bad. Okay, we got an idea. Let's do 2 bottles. That's got to work, right? And we can sell 2 bottles instead of 1, and we're all good. And they tried it against lidocaine again. Didn't work. They're like, whoa, this is bad. Let's try it against placebo. But did they back down to 150 milligrams to try it against placebo? No, they did not. They left it at the 300 milligrams that they had tried and failed against lidocaine to begin with. And lo and behold, 300 milligrams of amiodarone is better than lidocaine, better than placebo at converting pulseless ventricular rhythms to pulsed rhythm. That is the data upon which you're giving 300 milligrams of amiodarone. Now, the first dose is 300 milligrams. The second dose is actually 150 milligrams. So it's not a higher dose, it's a second smaller dose at the smaller amount. Now, why 300 milligrams didn't work and you think 150 is going to? I have no idea, but that's what the algorithm says. And so the American Heart Association wants you to use amiodarone as the first antiarrhythmic on the algorithm, 300 milligrams, then 150 milligrams. And then, if those don't work, you can go to lidocaine, which comes in an amp. Okay. First dose, 100 milligrams, or an amp. Second dose, 100 milligrams, or an amp. Because guess what? It's pretty darn good stuff. Not that amiodarone is a great drug. Don't get me wrong. It's a phenomenal drug. It works for a lot of things. And I suspect that it's a better drug than lidocaine, but I think that the number needed to treat if you've already failed shocks and epi and etc. is just so high that you can't prove statistical significance, would be my guess. So anyway, so then you give the 2 doses of lidocaine, and again, this is in this drug shock thing, with epi interspersed every 2 to 5 minutes, wherever you want to do it, drug shock. And then, if 2 doses of lidocaine don't work, there's one more drug on that algorithm. Procainamide. Okay? So, amiodarone 2 doses, lidocaine 2 doses, procainamide. I will tell you I haven't used procainamide in like a bajillion years, because by the time you get that far down the line, people have either gotten better or they've shocked to asystole and you kind of call the code. But those are the 3 drugs. Now, how are you going to remember those 3 drugs? So if you look up at that rhythm on the monitor, can I convince you that that is a mountain range? Yeah?
Sure.
Everybody buy that? Can I convince you that it is a very odd and craggy area of the Alps? Yes? So
I'll buy it.
when you see the Alps, ski the Alps, okay? So Alps, amiodarone, lidocaine, propanamide, and the S is shock, if you will. So when you see the Alps, ski the Alps. So when you see the Alps, I want you to think about the Alps drugs, okay? And the Alps is the order that they want you to give it per ACLS.
And so it's 2 amiodarone, 2 lido,
So
2
it's-
doses,
Yeah, so it's, so,
300 then 150.
right, and then
Amp,
amp,
and then
propanamide would be the next thing. But again, it's rare to get to propanamide just
Okay.
because it's been going on so long. When you're doing epi every 2 to 5 minutes, and then you're doing those other drugs every, and you're shocking, et cetera, et cetera. So, but that's, yes,
okay.
that's the deal.
Okay.
So, we've just done pulseless VTVF. That is pulseless VTVF. There's one related rhythm called torsade. You guys know what torsade looks like? Yes? That sort of undulating bass line. There's one difference with torsade in this situation, and that one difference is
Magnesium.
magnesium. Right. Where does the magnesium go? Not in the patient, but in the algorithm.
At the beginning?
At the beginning, right. So, magnesium is the first antiarrhythmic, clearly. Okay, so it goes before amiodarone, before lidocaine, before. You can give epi with, before, after the magnesium. Shocking is still first. Magnesium, shock, epi, or you can do shock, epi, shock, magnesium. And how much magnesium do you give?
2.
How did you know that?
I just read a chart where someone went to torsades and coded.
got 2 grams
Yeah.
of magnesium. So
I didn't know if that was right, but
2 grams of magnesium is a really good number to remember, because 2 grams of magnesium is possibly helpful and definitely not harmful for almost every problem in medicine besides diarrhea. So like literally anybody has any problem, 2 grams of magnesium is a right answer, completely. So how do you remember 2 grams?
2 plus charge.
2 plus charge, exactly. The charge on magnesium is 2 plus. And so that's how you're going to remember that that's the dose, okay? Charge on magnesium is 2 plus. Okay, so that's, and it's grams, not milligrams. I don't know how you're going to remember grams, but
Does it come in an amp?
no. But 2 grams of magnesium is a really useful number to remember. Questions about pulseless ventricular rhythms?
Is there an amount of time that you have to wait between shocks?
No. But you're supposed to do a drug between shocks, and
Okay.
there's an amount of time that you're supposed to wait between drugs.
Okay.
So what takes the time, if you will, is letting that drug circulate and have the time to have an effect before you do the next shock. Does that make sense?
So then you would check the pulse, then check the rhythm, and then shock them
Yes,
after 2
exactly.
to 5 minutes.
Yeah. So I give the whatever I gave my drug, that do CPR for 2 to 5 minutes. I say hold CPR. I do a pulse and rhythm check. Pulse and rhythm, no pulse, continues in this rhythm. Continue CPR, charge the defibrillator. Charge the defibrillator, woo, hold CPR, everybody clear, la la la, shock, pulse and rhythm check, continue CPR, give the drug, whatever the next drug is, CPR for 2 to 5 minutes.
Okay.
Does that make sense?
Yes.
So hands-on CPR as much as possible, and stop CPR to check pulse and rhythm whenever you need to. But whenever you need to is about when do I expect a result? from the thing that I just did. Yeah?
Yeah.
Okay, so we just did 3 algorithms, pulseless VT, and torsades, right? Pretty easy, really. Alps, you see the Alps? See the Alps, and epi and shocks, right? Okay, questions about that?
I
Yes.
have a question about timing of antiarrhythmics with epi. So epi is every 2 to 5.
Right.
And do you like swap an antiarrhythmic out for the epi essentially,
Yeah,
or could you
essentially-
be giving 2 drugs?
No, you don't give 2 drugs at the same time. And the reason for that is really like you're trying to see what did something. If you give amiodarone and it converts them, and then you give epi when they've come back to life, you could then, raise their blood pressure and give them a stroke and a heart attack and all kinds of bad things, right? So you want to do one thing at a time. Okay. So usually it's going to be shock, epi, shock, amio, shock, epi, shock, amio, shock, epi, shock, lido, shock, epi, shock, lido. Does that make sense?
Yeah.
Something along those lines. If you're following the ACLS protocol. I'm going to tell you, many people, based on the data, many emergency physicians, based on the data, actually give lidocaine before amio in this situation, because you're going to go to amio anyway if the lidocaine doesn't work. There's no data to show that amio is better. There's a lot of data to show that amio is more expensive. And so a lot of people do laps. But that is not what the American Heart Association wants me to teach you. But I'm not teaching you ACLS, so I can teach you anything. But ACLS is a recipe, okay? And it is a cooking recipe, not a baking recipe. I don't know if any of you are chefs, but don't mess with baking recipes. Like, this is a piece of advice. Never, ever alter a baking recipe unless you're a chemist. But cooking recipes, you can do anything you want with, right? You can throw in some spices, take something out, just alter it the way you like. So ACLS is a cooking recipe, and it's not something that you have to do. Now, as far as you got to a point where you had kind of run out of drug ideas and shocking, and had been going on a long time, and you're like, I'd like to think about other things that may be causing this. That is a noble thought, but it's not actually part of the algorithm. You don't actually need to think during this algorithm. So all you need to do is like this subtentorial knee-jerk response of these drugs. There is no thinking involved. Once the patient becomes alive again, then you have to start thinking, right? But you're not going to send labs on a dead person, right? This is ludicrous. There aren't that. Yes, there might be underlying causes. A troponin, so they had an MI that killed them. How is that going to help us? Now, if they come back to life and all of a sudden you get a 12 lead and they have ST elevation, by all means send them off to the cath lab. But it doesn't matter what the underlying cause is because they're dead and they're not coming back to life, and there's nothing that you can do in this scenario to change that. Does that make sense? So noble idea, though.
Even like a finger stick, you.
So it's not part of the algorithm.
Yeah.
So usually, what I'm going to tell you is that people die in a different way due to hypoglycemia, and we will get there.
Okay.
Okay? BFib is not one of the terminal things with hypoglycemia. Okay. So, any other questions? Pulseless ventricular rhythm. Okay, so switch up the roles and we'll do the next bit. Mrs. Smith, she is 76 and she comes in complaining of palpitations.
Okay. That's it. Go see.
Yep.
And you're going to be the patient, right?
The patient will speak to you if she can.
Okay, so Mrs. Smith,
Yes?
how are you feeling right now?
Well, goodness
Goodness gracious, my heart is just beating right out of my chest.
Okay, any chest pain?
No,
No. Have you ever had anything like this before?
never.
Never. Do you take any medications?
Well, I take an aspirin a day because they say that's good for you, but that's about it.
Okay. Any heart problems ever?
Never.
Never. Okay. Feeling lightheaded or dizzy?
No, but my heart is pounding really hard.
When was the last time you ate anything?
Well, you know, I just got up this morning and I was about to cook my breakfast and then this started, so I came right in. So I had dinner last night.
Okay, so you haven't had anything this morning.
No.
Okay, can we get a 12 lead?
The machine
in the
is
OR?
in the
Service.
OR right now.
Sweet. Okay.
Or you get a 12 lead, you wait for a 12 lead, and
it just shows
it
VTAC.
essentially shows this same thing in every lead.
Okay, which is just VTAC. Okay, any trouble breathing?
No.
Nope. Okay. All right. So I think we can do a synchronized cardio version for VTAC, right? So I don't know, 200
Okay.
joules.
What are you talking about?
So I think your heart's in a funny rhythm, which is causing you to feel like your heart's beating really funny, and it's really fast. So I think what we're gonna do is we're gonna try and shock you out of it.
Goodness gracious, that sounds very painful.
Yeah. So we would give you propofol.
Okay.
We're gonna
not
sedate you
find
well.
propofol. Sorry, we don't
But we're
leave
gonna
that
sedate you. We're
line
gonna give you some meds, so you should remember, and it shouldn't bother you at all. Okay.
Okay, do I have to have that done?
I mean, I would like to do it. So
Okay,
that
well,
we
you're
can
the doctor, so I just wanted to just
Okay.
make sure. It just sounds really scary.
Okay, don't worry. We're all going to be here to help you. We have people here to help you breathe if you need it, and we're going to give you some happy meds, okay?
Okay,
Okay.
so happy meds,
Yeah.
and she's asleep.
Okay, good. And we have Ben ready to bag if we need it, and we have that synced up. Okay, let's
And
start.
what joules?
200?
200 joules. Yep. Okay.
Okay, and let's charge it.
Everybody clear? Docking.
So that works. She's now asleep because
Yeah.
she's propofolized.
But she's breathing
But
okay.
she's breathing, and so
that's good.
yeah, so she's back in sinus rhythm.
Okay.
Is there anything you would want to do at this point?
Well, I'd probably do another 12 lead.
Okay, and it looks fine.
Just to see how that
It
looks,
looks
yeah.
fine.
And probably draw some labs.
Okay.
And I think that would be it for
Okay,
now.
great. Code or scenario called. I was super encouraged to hear you start asking her, are you having chest pain? Are you having shortness of breath? Do you feel lightheaded? Etc. Because those are things that you need to know in order to assess stability, right? So as soon as you decide if somebody, the very first decision is, are they dead or alive, right? That's decision number one, dead or alive. Once you decide they're alive, the very next decision is, are they stable or unstable? Because if they are unstable in any rhythm, if they're alive and unstable in any rhythm, the first thing you do is synchronized cardioversion.
Alive and unstable.
Alive and unstable, right. If they are alive and unstable, the treatment is synchronized cardioversion. So unstable means low blood pressure, chest pain, shortness of breath, altered mental status. Those are the things you assess for instability. Okay? So I was really encouraged to hear you ask her those questions. A lot of people don't remember to ask those questions. But then you got the answers to the questions. Did you think she was stable or unstable, or were you not even thinking that? You were just sort of
Well, I thought
asking
she was
questions?
stable, but then I was just so afraid she
You
was
were
going to
so afraid she was
die.
gonna die. Okay. So what I saw happen is you asked the questions, it seemed like the answers all led to the
Yeah.
idea that she was stable,
Yeah.
and then you treated her for unstable
Right.
VTAC.
Yeah.
And so that was based on fear on your part?
Yeah.
Okay, so here's my question. Do you think that the risk to the patient is higher to do conscious sedation and shock or to give drugs?
It's probably higher to Sedator. And, yeah.
Right. And if you were going to choose for yourself,
Yeah.
would you prefer to get conscious sedation and shock or drugs?
I guess it depends on how crummy I felt, but if I
She
just had
felt fine.
palpitations,
Yeah,
I
she felt
probably
fine,
want the
right?
drugs.
So once you decide somebody is stable, then there's an algorithm for that, right? If at any point during that algorithm, if they start off stable and then suddenly become unstable, you convert to the unstable algorithm and shock them, right? So you go over here if they become unstable at any point. So if she had started complaining of chest pain or started mumbling about her cat or her blood pressure had dropped or whatever, then you shock, right? But you start off saying, this is a stable rhythm. I have time to let medications work, right? So what medications might work for this woman?
Diltiazem.
Okay, where does diltiazem work in the heart?
Okay, calcium channels.
Okay, calcium channels, specifically what structural part of the rhythm making stuff does it affect?
Either the SA or the AV. Probably
Okay.
the SA. No.
Okay, so it's above the ventricle,
Mm-hmm.
yeah?
I think so.
What rhythm were we in?
A ventricular.
Ventricular rhythm. Does the ventricle care what happens above the ventricle?
No.
No. So it's like you're driving a car to work, right? You've got the radio on. You hear there's a car accident. You want to go into ER and you're on your way to your ER shift and you really want to impress people, right? There's a car accident behind you. You're like, ha ha ha, I got to work on time, I made it past. There's a car accident in front of you. You're like calling the attending, right? You're worried. Because the heart only cares what is downstream. What's behind it? Done. Can't worry about it. So diltiazem does not work for ventricular arrhythmias. And in fact can be kind of dangerous and kill people. So calcium channel blockers, not good in ventricular arrhythmias.
Great.
What else?
Lidocaine.
Lidocaine. Very good. What else?
Could you do the Alps?
Alps. Very good. Can you put that rhythm back up? So, can I convince you that we are in a mountain range? Very different area of the Alps, right, than the last area. Completely different, right? But it's nonetheless potentially an area of the Alps, right? So when you see the Alps, ski the Alps. So the same drugs, the patient has the same underlying problem. You're taking the computer to COM-IS for the same problem, which is a ventricular arrhythmia. And the same drugs that work for ventricular arrhythmias in a dead person work for ventriculars, lo and behold, in a live person. The problem, the underlying problem is the same problem. It's just that the patient is a different patient, right? So it's the same drugs, except you skip the dead person stuff. So you skip
CPR and shock.
CPR, you skip defibrillation. You might shock, right? You might cardiovert at some point, but you don't defibrillate. You skip CPR, you skip defibrillation, and you skip epinephrine because the amps of epi are dead person stuff, right? So IV amp of epi we use in dead people in these scenarios. So, but it's just the same drugs. Now, amiodarone is packaged in 150 milligrams because it is proven to be better than lidocaine in converting a pulsed ventricular rhythm to a sinus rhythm. So amiodarone is truly proven to be better in this scenario than lidocaine. So Alps, you start with amiodarone, 2 doses of amiodarone. The difference is that in this situation, 150 milligrams is proven to be better, and so the 2 doses are
both 100.
both 150 milligrams. Okay? And then 2 doses of lidocaine, an amp each, and then procainamide. Usually people have gotten better, but if not, if you reach the end of the algorithm and people haven't gotten better, then you can shock, synchronized cardioversion. If at any point they become unstable while you're giving those drugs, you immediately go to synchronized cardioversion. But you can go down that Alps path. And once they come out of the rhythm, and this is true in pulseless ventricular rhythms as well. You hang a drip of the last antiarrhythmic that you gave, or if you never gave an antiarrhythmic, you just shocked or gave epi and shocked, the first antiarrhythmic on the algorithm, which is amiodarone. Okay? But if you gave amiodarone and then you gave lidocaine, then you hang a lidocaine drip. So the last antiarrhythmic that you gave or the first antiarrhythmic on the algorithm. As far as the number of joules, the ventricle shocks between 200 and 360 joules. Same as it did in the dead person, shockingly. So, in this situation, the choice is yours of how many joules to use. Now, unlike the last lady, this person's alive. She actually was kind of concerned about the shock to begin with. If I was going to ask you, do you want to be shocked with 200 joules or 360 joules, which would you choose?
200.
200, right. All of you, I would choose 200. But if I asked you, do you want to be shocked with 200, then 300, then 360, or 360, which would you choose? You'd choose 360. So there's no way of knowing a priori which of those things is going to happen. So it is appropriate to just say shock with 360 joules, or it's appropriate to start at 200 and then escalate. What I will say is probably the best guess that you can make is based on habitus. So if somebody is 500 pounds, don't start with 200. Just go to 360. If somebody is 62 pounds soaking wet, probably you might even be able to get away with less than 200, but the algorithm says 200. So habitus, just the more tissue that's between the heart and the shock, the more dampening of that electrical stimuli, and so that's that. But there's not a right answer. The ventricle shocks between 200 and 360 joules, and you can choose. If you can't remember anything, you can crank it to the max, right? in ventricular rhythms. Okay. Questions about pulsed ventricular tachycardia?
How long do you wait between medications?
Oh, 5 minutes or so.
Okay.
Yeah, same as you did before. No other questions. So it's the same. It's basically the same algorithm as before, except you need to decide, are they stable or unstable. You skip the shock, the defibrillation shocks, and you skip the epi, and you lower the dose of amiodarone. But we're still in the Alps. We still see the Alps. Can you put SVT up there? Can I convince you that that is of mountain range?
No.
No, right? Maybe a telephone pole farm or something, but not a mountain range. It's too acute, right? There's nothing in nature that is mountainous that is that acute. So that is not an appropriate setting for the Alps drugs. But the wide complex rhythms, the ventricular rhythms, when you look at a rhythm and you go, ooh, that looks like the Alps, right? Then think Alps drugs. This is the wonderful invention. Okay, thank you. So, no other questions about this?
In torsades, are they always going to be pulseless? Would they ever be?
No, if they do it for a very short period of time, they can be pulsed, but it's short. It will be pulseless pretty darn quick.
Okay.
And how long? I mean, I guess the answer is as long as they're stable. But for VTAC, I always thought VTAC was also a quickly.
Some people can be in VTAC for a long time.
Okay.
It has the potential to quickly deteriorate to pulseless VTAC or VFib, for sure. I mean, your ventricle is screwing up.
Yeah.
It's a very dangerous rhythm. But you can be stable in that very dangerous rhythm
Okay.
indefinitely.
Okay.
Really. What was I just going to say? Okay. Yeah. Okay. Other questions? If not, we'll go on to the next thing.
Oh wait, I do have one more
Yeah.
question. how much of a assessment should be done before like giving those drugs? Just we knew she was in VTAC.
Yeah. So the as you said, your impulse of this is dangerous, super important, right? Because it's true. So she's not having any other symptoms. She's in VTAC. Go ahead and treat her.
Okay.
If she's complaining of shortness of breath, it might be worthwhile listening to her lungs and see if she's got rails 3/4 of the way out. Stuff like that. But how much more do you need to know besides she's in VTAC and we need to get her out of it.
Yeah.
Right.
Okay.
So not a lot. Okay. So switch up the roles. So this is the next door neighbor of the guy in the elderly care home, elderly housing facility. Other side of the wall. He hears a crash in the apartment next to him. Goes over, knocks on the door. No answer. Calls 911. 911 comes. They break down the door and they find this elderly lady, looks to be in her late 70s, lying in the middle of her floor, unconscious. And she's got an IV in place, and she's in your ER, hooked to the monitor, just rolled through the door.
Pads are on.
Pads are on,
What's
everything's ready.
Patient's name?
Mrs. Smith.
Mrs. Smith, can you hear me? Okay, unresponsive. Can we check for a pulse? Can we check for a pulse and check for breathing? Okay.
No pulse.
Can we call the code and start CPR?
In the ER, you don't call a code
Okay.
because the no code team comes.
Okay,
We
can
are.
we ventilate 10 breaths a minute?
Okay. And 2 to 5 minutes or however long you were going to do CPR has passed.
Okay, can we do a pulse check?
No pulse.
Okay. Resume CPR, keep ventilating. Can we prepare an amp of epi?
Yes. 1 amp of epi.
And 2 to 5 minutes has passed.
Okay, can we do a pulse check and rotate chest compressions?
I don't have a pulse.
Okay, we're just going to start compression and continue ventilating. I'm still seeing asystole up there. So can you prepare another amp of epi?
And 1 amp of epi.
And 2 to 5 minutes has passed.
Okay, can we do a pulse check? And
No pulse.
rhythm still showing asystole. Okay, resume compression. And another amp of epi.
Amp of epi.
And 2 to 5 minutes has passed.
Can we do a pulse check and rotate chest compression?
No pulse.
Okay, still seeing asystole. Can we resume compressions? And prepare another amp of epi.
1 amp of epi.
And 2 to 5 minutes has passed. We're now about 20 to 30 minutes in.
Can we do a pulse check? And I'm still seeing asystole.
No pulse.
No pulse, no respirations. Resume chest compressions. And continue ventilating. And 1 more amp of epi. We're out of epi.
Last amp of epi.
And 2 to 5 minutes has passed.
And let's do a pulse check. I need reading.
No pulse.
Still seeing asystole. I'd probably call it at this point.
Okay, do you know how to call a code?
No.
Okay, so let's call the scenario. We'll talk about it. The bugaboos that people have in this scenario, which I'm going to just put out there even though you didn't do them, are that some people start off, they're like, okay, it looks like asystole, and they start running the code, and then you're like, oh, it's not asystole. So,
It happened up
you know you saw a rhythm at some point, but you kept saying it's asystole, and you were very good about checking pulse and rhythm and holding CPR during that. But that is a common error. The other common error is that people shock this rhythm or give antiarrhythmics to this rhythm. So, is this the Alps?
No.
No, it is not the Alps, right? It is the plains. The plains has no antiarrhythmics. So, semantically speaking, this is an arrhythmia if you say a means without and rhythmia means rhythm, but it's not an arrhythmia in the sense of we need to change the rhythm per se. We just need to get a rhythm, right? So, there is nothing to do except epi, essentially. I mean, you can put somebody on an LV assist device or, whatever, but this is not a survivable rhythm most of the time to out-of-hospital discharge. I personally don't like remembering what's a shockable rhythm and what's not a shockable rhythm because, to me, remembering anything is a setup for failure. So I like to think about why am I shocking somebody? And that tells me whether the rhythm is a shockable rhythm or not shockable rhythm. So we shock out of rhythms, not into rhythms. So if you don't have a rhythm to shock out of, don't shock. Those aren't shockable rhythms, okay? When I was an intern, I had a resident that used to say you can't pace a steak. Similar idea. Meaning, if I take this machine into the meat department at Hannaford's and I slap these pads onto a piece of steak, I might have myself a little barbecue, but I'm not going to get a cow that runs out of the room. So we shock out of rhythms, not into rhythms. You can't pace a steak. That's how you remember, when you look at this and go, well, is it a shockable rhythm? Is it not a shockable rhythm? Maybe none of you guys would have this problem because you knew this anyway, but maybe you only knew it because you read the algorithms last night. I don't know. For me, it helps. I'm shocking out of rhythms, not into rhythms. Nothing to shock out of here. So those are the bugaboos that happen to people, but you didn't do them, so you failed being the classic with your medical student. You remained super calm. Like the vibe in the room was really super calm, which is very nice. To not have this sort of hyped up vibe. So as far as calling a code, the things that have to happen are you have to say what the rhythm is and that they are pulseless, and you have to say the time of death and call the code and say the time of death. Those things have to happen. Now, if you're calling code in asystole, most people will check a second lead. Because have you ever seen a 12-lead EKG where there's like rhythm and everything, and then there's one line that looks that is isoelectric, and so it looks like asystole just in one lead? Have you ever seen this? So wouldn't it suck to call a code on somebody that actually had a rhythm, but you're just not seeing it because you're looking at it from an isoelectric direction? So you say, could you check a second lead? The nurses press some button, and I don't know what button it is. And they basically just switch the direction at which we're looking at it from. I've never actually seen it change in my 30 years of practice, but whatever. It's a good idea to do. Or maybe you'll see that this is actually fine V fib in that lead, something that will change what you do. So you say the patient remains asystolic in 2 leads. They remain pulseless. I usually call out findings consistent with death. So I'm like, their pupils are fixed and dilated, they have dependent lividity, they have rigor mortis, whatever it is that sort of supports my diagnosis that they're dead. And then I personally say, is there anybody in the room that has any objections to calling the code? That gives people the opportunity to speak up if they, A, have some knowledge that you don't have, which, you know, might be the case in an internship year. Or B, just have some philosophical difference with you in the way you ran the code. And where this comes up most commonly is in young people. So it's rare in a 90-year-old for somebody after one round of epi to say, oh, I don't think you should call that code. But if you're talking about a 17-year-old that overdosed on heroin, you know, people emotionally have trouble with calling it after. It doesn't necessarily change the outcomes, but it changes the way the healthcare team feels about the job that they did and the effort they put in, which is super important. So I always say, is there anybody that has any objections to calling the code? Twice in my career, people have spoken up and said yes. Both times they just said, I don't think you ran it long enough. Both times I ran it longer, both times the outcome didn't change. But it's important that the people who are working with the patient feel comfortable that the right thing was done, especially in situations that you don't expect a death. And then you say the code is called at such and such a time. Thank you, everybody. Turn off the monitors, because you do not want the monitor on and some agonal beat to go up as the janitor walks by with no knowledge base, sees the agonal beat, sees that everybody's left the room, and, you know, so you, once you call the code, code's done. Monitor's off, and that's it. Okay? That's how you call a code. So asystole is super easy, right? It's epi. Notice anything familiar about these scenarios, like epi is the first drug, epi's the first drug, epi's the first drug, right, for dead people? Epi's the first drug. So again, you don't even have to think. If you walk into a room with a dead person and it's a medical code as opposed to a trauma, and you want to resuscitate them, you can always call for epi as the first drug. It's not necessarily the right first thing, like shocking is the right first thing if you have access to the shocker, but the right first drug, you'll never be wrong if you say epi. Torsade, if you throw magnesium in first, that's fine, but you're unlikely to have it available first because it has to be like mixed or, you know, gotten out of the Pyxis or something that's not in the code cart. So epi is a right first drug, and you don't even have to think. You just say epi, an amp of epi. Okay. Questions about asystole? Epi, 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 until you're tired of giving epi. Again, no evidence to show that more epi leads to better outcomes. In fact, more epi leads to worse outcomes, if at all imaginable. Asystole has abysmal outcomes, like abysmal, to out of hospital discharge, even if they code in the hospital. This is not a joke. When your heart does this, it's not like, haha, just kidding. You know, this is like something bad happened to make your heart do this. Okay. Okay. Who's running this one? You are. Okay. So, the guy in the elderly care facility, hears a thump on his ceiling.
Oh no.
He runs up the stairs, knocks on the door, no answer, calls 911, police come, break down the door, find his neighbor, upstairs neighbor, lying on the floor, unconscious, bring her to the hospital.
Okay.
And she is here. And her name also is Mrs. Smith.
Okay. Moosh, can I have you check the pulse? And Meg, can I have you check for breathing?
Sure.
I don't see anything.
No. Mrs. Smith, can you hear me? No, nothing. Okay. So it looks like she's pretty bradycardic. Could I get a
Really,
amp
to see your
of
pulse.
atropine.
Top drawer, pink, or purple box.
1 amp of atropine.
An amp of atropine, which is a milligram of atropine.
Go
Yeah,
ahead. Yeah.
maybe, yeah, it's really.
There is no pulse.
Yeah, I was gonna say I don't.
Oh, there's no pulse. Okay. Why don't you start bagging and actually start with chest compressions.
And 2 to 5 minutes has passed.
Let's hold compression and check for a pulse. Okay.
No.
So she's still bradycardic,
No pulse.
no pulse. So continue compressions and we get another amp of atropine. Atropine.
1 amp of atropine.
And 2 to 5 minutes has passed.
Okay, so we'll hold compressions for a minute and check for the pulse again.
I'm still not seeing her chest rise here.
No pulse.
Still no pulse.
I might have you lift her jaw while I bag.
Noosh, could you start on compressions?
Here, I'm gonna bring the bag over here.
Could I get another amp of atropine?
Do you feel it raising around here?
I think so.
1 amp of atropine.
Okay,
And 2 to 5 minutes has passed.
perfect. Let's hold compressions and check again for
I still don't see her chest rising.
No. No pulse.
Okay, continue compressions.
And we
Can
can
I get
switch over to
an
me
amp
if
of
you want.
Amp of epi or a milligram of
At the
epi?
next, next pulse check, let's switch.
1 amp of epi.
Can you lift her jaw?
And 2 to 5 minutes has passed.
Can we pause compressions and check for a pulse?
No pulse.
Pulse, okay. Resume compressions.
Can we get it?
Mitch, can you help me by lifting the jaw over here?
Can we get
And you can hold her and ask me.
3 amps of atropine?
If they aren't there, just pretend. 3 amps of atropine, okay?
Great.
2 to 5 minutes has passed.
Okay, let's check for a pulse again.
I do not feel it pulse.
Okay. She's still really slow. Let's get back on compressions. And another amp of
Try not to push her jaw, lift her jaw in.
1 amp of epi.
Okay.
And 2 to 5 minutes has passed.
Hold compressions and check for a pulse.
You do not feel the pulse?
Okay, let's resume compressions. And let's do another 3 of atropine.
I want to call the scenario.
Okay. Yeah.
Have any of you ever seen somebody with a pulse of 50?
Yeah.
And how were they?
Great.
They were great,
Yeah.
right? They were either fine. Many of you may have a pulse of 50 at rest, right? Fine. Or maybe if they were older, they felt a little lightheaded or dizzy or something like that. Yeah? Any of you ever seen somebody with a pulse of 50 that was dead from their pulse of 50?
No.
No. So the problem is not that the guy has a pulse of 50. Yes, she is bradycardic, but that is not the problem, right? Because a pulse of 50 does not kill you, right? You've never seen a dead person with a pulse of 50. I mean, so what's the problem?
There is no pulse?
There is no pulse, right. So but why?
Hypoglycemia?
Okay, well, so what do we call this?
PEA.
PEA, right, pulseless electrical activity. So we have no pulse, they're pulseless, and yet there is electrical activity. Now, I'm going to say that semantically speaking, again, if we look at just the meaning of the words, pulseless VT and VF are pulseless electrical activity too, right? There's no pulse and there's electrical activity. But we don't call those pulseless electrical activity because in order by definition to call something pulseless electrical activity, we need to have a rhythm that should be generating a pulse that isn't. So VFib can't generate a pulse, and pulseless VT we call out as its own entity of pulseless ventricular tachycardia. VT can either have a pulse or not have a pulse. So we separate those out. Those we know are the Alps. We're in the Alps with those ventricular rhythms. Pulseless electrical activity. There is a rhythm on the monitor that should be generating a pulse that isn't. That's what we call pulseless electrical activity. Now, I told you that all dead people of medical etiology who you want to resuscitate, the first drug you can give them is epi, right? So you can give epi for this ad nauseum. Do we need to shock out of this rhythm?
No.
No, it's a perfect rhythm. This rhythm is better than my rhythm. So it's not PEA is not a shockable rhythm because they're in a rhythm that should be generating a pulse and is a totally fine rhythm. So we don't shock out of the rhythm. Do we need an antiarrhythmic for this rhythm?
No.
No, we're in a sinus rhythm, right? So what is there to do? What's up?
Would you be worried that they don't have enough volume?
Oh, hey, so I heard you say somebody say hypoglycemia. I heard you say volume. Is this ringing any bells for you guys?
H's and T's.
H's and T's, right? Reversible causes.
Yes.
So PEA is the first time in all of ACLS where you actually have to think.
Okay.
Okay? This scenario requires ATP use in your brain.
Okay.
So, does H's and T's help you? It doesn't help me. I mean, there's so many words in
Yeah.
medicine that start with the letter H and start with the letter T. For me, that is an entirely unhelpful mnemonic. I don't know. If you like H's and T's, by all means be my guest. What I want you to think about is when you have pulseless electrical activity, you can try and bring them back to life with epi, but there is an underlying reason why this is happening, okay? And the way to bring the person back to life, really, is to treat the underlying reason. And those underlying reasons are the H's and T's. I'm going to tell you that there are bajillion and one underlying causes of PEA. You're never going to be able to list them all. But I will tell you there's a very limited number of causes of reversible causes of PEA. And those are the ones we care about, is the ones we can actually do something about and fix. Okay? So H's and T's refers to some of the reversible causes of PEA, but you have to do some gymnastics to make them be H's and T's, and So if you like H's and T's, by all means be my guest, stick with the H's and T's. I will tell you my decreased RAM way of thinking of this is there are two structural causes wherein the pressure outside of the heart exceeds the pressure inside of the heart, collapses the right atrium, possibly collapses the right ventricle. If the right heart is collapsed, no blood can get in, no blood gets in, no blood gets out, right? So what are those two structural causes?
Cardiac tamponade.
Tamponade and tension pneumo, right? So both of them put pressure on the right atrium, maybe enough pressure to collapse the right ventricle, and no blood gets into the heart. So how might you know if somebody has a tension pneumo?
Breath sounds.
Breath sounds, no breath sounds on one side, tracheal deviation away from the side of the pneumo. What else?
Hypotension.
Dead. That's the ultimate in hypotension.
Trauma history.
Okay, so maybe they have a trauma history. Maybe they have a spontaneous pneumo, who knows?
JVD.
JVD, right?
Yeah.
So increased, right heart backup. Okay, so, and if somebody has a tension pneumo, or you think they have a tension pneumo because they have those findings, what might you do?
Needle decompression.
Needle decompression. So you take an IV catheter, which you get in the drawers with the IV stuff, not the little shorty ones, but the longy ones, the biggest one you can find. If that's an 18 gauge, it's an 18 gauge. Ideally, you want a 16 or a 14 gauge, but oftentimes those are not immediately available, in a regular room. Biggest catheter, IV catheter, angiocatheter you can find. You take it, you stick it mid-clavicular line, second inner space, just above the rib. So that's like just below the clavicle. I got a little, marker for around that area. So we're, right in here. And you take it 90-degree angle, just stick it in and pull out the needle. Leave the catheter in place. If you hear a rush of air and the patient suddenly gets a pulse, then you put in a chest tube and you have cured them. If there's no rush of air and they don't get a pulse, you just leave the catheter in place and carry on. Okay? How might you know if somebody has a pericardial tamponade? Ultrasound, okay, if you have that available.
JVD,
JVD, okay.
hypotension.
Dead, ultimate in hypotension.
Muffled heart sounds.
Dead heart sound.
That's, I don't know.
There's one other way besides ultrasound.
ECG. EKG.
ECG is just
Oh.
going to show you. I mean,
Yeah,
you may see
electrical.
electrical alternans or something like that, but
Chest X-ray.
chest X-ray might just show you a big heart. It might not show you anything, and they're dead. Why would you get a chest X-ray in here? Put a needle in it.
You just go right on in.
You go right on in. They're dead.
That's true.
Like, this is the perfect person to learn how to do pericardial. Seriously. No, I'm totally serious. Like, wouldn't you, when you have a live patient that needs a pericardiocentesis, hope that you'd already done it on a dead patient? So this is the perfect person, if you don't have ultrasound available, to practice pericardiocentesis on. Spinal needle. You've seen those, right? Big long spinal needle hooked to a 60 cc syringe, big spinal needle, like 18 gauge spinal needle, hooked to a big syringe. You go in at a 45-degree angle to the skin, aiming subxiphoid, aiming for the left shoulder, drawing back as you go in, okay? And you will either, if it's a serous effusion, yellow stuff will come out. There's nothing yellow up in that general vicinity. If you're pointing the right direction, the only yellow stuff you're going to find is bladder, right? So if it's a serous effusion, yellow stuff will come out. If it's a bloody effusion, you'll hit blood. How do you know if it's pericardial blood? Where's the blood coming from? Like, if you hit blood, where's the blood coming from?
The heart.
Could come from the left ventricle, right? Or it could come from a pericardial effusion. How do you know the difference?
How fast it's coming out?
What?
How fast it's...
Person's dead, so the only, it's, you're drawing back and
Is it the color?
they're dead. Everybody has dark blood.
They get
The amount, like it stops or it just keeps
They get
going?
better, okay, that's the ultimate way of knowing that it's a pericardial effusion, yes. But what if you've drawn off 60 cc's and they still haven't gotten better? Do you just need to squirt that out and draw off more? Or are you in the left ventricle and you just are going to draw off their whole blood? So, when blood... Ultrasound, right.
Don't get the
ultrasound. That's the ultimate, and these days that is, very, very common. When I trained, that, wasn't necessarily a thing. So when blood sits in the pericardium, what does it do?
Clots.
Clots, right. So when you stick a needle into the pericardium and you draw off liquid that looks like blood, it has used up all of its clotting factors, and there's a clot left in the heart. So you draw off that liquid component. It still looks like blood. You can't tell the difference in the way it looks. But it doesn't, if you squirt it out into a basin, it doesn't clot because it's already used up its clotting factors. Versus if you have blood that you're drawing off from the left ventricle that CPR has been going on and it's at least moving around, you squirt it into a basin and pretty quickly it clots. So we call pericardial blood non-clotting blood. It's not magical unicorn blood. It just is blood that has already done its thing. Okay? But so those are the two ways to know if somebody has a pericardial effusion. Ultrasound or stick a needle in it. Ultrasound's super useful in this setting because not only can you tell if somebody has a pericardial effusion, you can also see if the heart is going like this with this rhythm or if it's going like this, right? And a little bit of squeeze gives you a little bit of hope that maybe something you're going to do is going to work versus if it's just sitting there, cardiac standstill, then that's sort of functional asystole, you know. So I don't run a PEA arrest without ultrasound. It's just, I just don't do it. No, nobody I know does these days. But if you're not an ER physician and you don't have access to ultrasound, you don't know how to use, whatever, that sticking a needle in it would be the way to do it. So A, it's diagnostic, B, it's therapeutic. So 2 structural causes, okay? Tension pneumothorax, pericardial tamponade. Those are the T's in the H's and T's. Tension and tamponade. T's, 2 T's. I like 2 structural. And then there are what I call metabolic causes. They're not really metabolic, but I'm a lumper, in case you couldn't tell. I'm going to group them into metabolic. And the way I remember the metabolic causes is that are reversible metabolic causes of PEA. What do you need to live? What do you need to live?
Oxygen.
Oxygen, right? And oxygen has a corollary
Carbon dioxide.
carbon dioxide, right? So oxygenation and ventilation, right? You need the airway dealt with. Now I know that oxygenation and ventilation are 2 separate things, but I'm going to call them airway, right? If you want to be a splitter, you can call them, oxygenation and ventilation. Because they are separate and you can oxygenate without ventilating. But you want to be sure you're doing both of those. Okay, so we need air, right? And we need like the right exchange of air. What else? We need sugar, right? It is the substrate of all energy production in the world, and not in the world, in living things. So we can either check a sugar, D-stick, bedside, right? And this came back to something you said earlier, I think. Like, would you check a sugar? Did you say that? Yeah. Or you can just give them an amp of D50. You can pull that out, Vanna White, from the top drawer. And show that's 25 grams of glucose. It's a big box. So that's an amp. When you hear an amp of D50, that's it. Okay, that's 25 grams of glucose. You can give everybody in PEA an amp of D50, or you can check a D-stick and see. But yes, you need oxygen, you need sugar. What else do you need?
Potassium.
You need potassium, right? You need the right amount of potassium. So, unfortunately, both high potassium and low potassium can cause PEA, and they both start with H. So, which one do we care? We only care about one of them. Which one do we care about? Hyper, right. Why?
Because it can cause arrhythmias.
You can do something about
So can hypo.
Yeah.
It can shock the heart.
You can just give calcium. And hopefully
Yeah,
stabilizes
Okay, but why do we only care about hyperkalemia and not hypokalemia?
It's reversible
It's reversible. Why is it reversible?
because of
Calcium. Okay, but how do we know if we want to lower the potassium or raise the potassium? I mean, we can send off labs, but then we're dealing with a dead person here.
KG leads.
So here's the deal. Have any of you ever given potassium to somebody? Never. No IV potassium. Anybody ever seen somebody with a low potassium? How low of a potassium have you seen? Oh, you've never seen anything below 3? Yeah. Yeah, so I've seen people with like 1.6s, 1.7s, They feel crappy, but they're not dead. Okay. So do you know how fast you can give potassium?
10 to 20 if it's central, if it's a central one.
Okay, 10 to 20 over what period of time?
Milliequivalents.
Over what period of time?
An hour.
An hour. 20 milliequivalents an hour. You can do that peripherally or centrally. So do you know how many milliequivalents you would need to give somebody to get their potassium from like 1.6 or 1.4 or 1 to 3 or some livable amount? You'd probably need like 100 or 120 milliequivalents. So we're talking about like 5 or 6 hours of coding them.
Wow.
Not going to happen, right? They're dead. If they're dead from hypokalemia, dead. Okay? But hyperkalemia, A, we can stabilize the myocardium, like you said, and B, we can do some stuff to at least temporize that potassium free to extracellular, intercellular shift, so that we can hopefully get the usable potassium lowered, temporarily until we can get them to dialysis, right? So, somebody said calcium, right? So calcium stabilizes the myocardial membrane. There, in a yellow box in there, is something called calcium chloride. So many people call for calcium gluconate because that's what you hear, okay? Calcium gluconate is not in the code card. If you're dealing with a dead person and they say, if you say I want calcium, and they say, do you want calcium chloride or calcium gluconate? And you can't remember, you say, I want the one in the code card, in the yellow box. And they say, how much? And you say, an amp. Right. So, it's calcium chloride in here because there's more elemental calcium per unit something or other, something in calcium chloride than there is in calcium gluconate. So when you start dealing in live people, we're giving calcium gluconate. Dead people, we're giving calcium chloride. So an amp of calcium. You can decide either everybody in PEA gets an amp of calcium, or you only give the amp of calcium to the people you think have hyperkalemia, which is also okay. So we've given the calcium. The calcium stabilizes the myocardial membrane, saves their life. Does it do anything for the potassium level? No. So what can we do to temporize this flux of potassium? Insulin. Good. If we give insulin, what's going to happen? We got to give them sugar, right? So maybe you've already given them sugar for their potentially hypoglycemia, but you give an amp of D50 with insulin. Now, how much insulin do you give? And how do you give it?
IV regular insulin.
IV regular insulin, how much?
10 units?
Yes! Very good! Oh, that's good! So I don't have a good, I know I've had a lot of like little, this is how you're going to remember this. I don't have one for 10 units of regular insulin, except that insulin starts with an I, and an I looks like a 1, and I don't know. It's 10 units of regular insulin. I don't have a good way to remember that. And it's IV push, and with an amp of D50. Okay, so insulin and glucose. What else can you give to move potassium around? Fluids, right?
Albuterol.
You can give albuterol in line, right? You can, once they're ventilated, you can blow albuterol in line. What else?
Caxylate.
Okay, caxylate will work over several days. We don't really have that kind of time on our hands.
Bicarb.
Bicarb, right. So have any of you ever treated DKA? So when you treat DKA and you start off their potassium, the number for their potassium is really high. But as you treat the DKA, they get hypokalemic. Have any of you ever seen that? Where all of a sudden you've been, high, and then their total body stores. So as you correct that acidosis, that potassium number comes down due to intra-extracellular shifting. So those are the things you can do for hyperkalemia. Calcium to save their life, insulin, glucose, bicarb, fluids. Okay, and then get them to dialysis. Now, you can do that in everybody with PEA, or you can do it in just the people who you think have high potassium. And who are those people?
Renal
Renal
failure.
failure.
Renal failure, number 1 cause. Who else?
They're on like a potassium sparing.
Potassium sparing diuretics. Good. Who else?
DKA.
Okay, but DKA has a high number, but a low total body potassium.
Total body, right?
Right. So you're not going to necessarily treat hyperkalemia in those people because they don't have hyperkalemia. They have hypokalemia.
Maybe people with like malignancies.
Okay, so malignancies untreated or treated?
Treated.
Treated malignancies, right? Sometimes people can have, chemo can cause cellular lysis syndromes, etc. Good.
Oh, crush injuries.
Crush injuries,
Right,
good. Who
yeah.
else? Think along the same lines, trauma.
Like acute limb ischemia.
Okay, limb ischemia. Who else? Burns, right? Spinal cord injuries that are not brand spanking fresh, and this is true with crush and burns. It doesn't happen when they hit the ER, it happens 8, 12, 24 hours out as things start to die and lyse, right? As their cells start to die. So spinal cord injuries, you start losing neuromuscular innervation, and you get atrophy, and those muscles start to die, and as they start to die, they release potassium. Chronic demyelinating diseases, muscular dystrophies, things like that.
Can AKIs cause that quick of a shift?
It can, yeah. I mean, you'd have to be a severe one, but. Okay, so 2 structural causes: tension pneumothorax, pericardial tamponade. Airway causes, sugar causes, potassium causes. What else do I need to lift?
Temperature.
We need temperature, okay? I call that a yeah but, so we'll get back to that. You're right.
Circulation.
Circulation, good. We need to turn on the hose, right? We need some water in the hose for water to come out the end of the hose. So everybody with PEA gets fluids wide open, okay? Because you want to make sure they have enough volume. Now, I will tell you that is according to ACLS. There is a new, and those of you in emergency medicine will probably hear about this over the coming years, a new zealoty kind of group that is pushing something called ultrasound-guided resuscitation, which makes sense, wherein you take the ultrasound probe and you put it on their IVC, and if they have a full IVC, then fluids are unlikely to help them, and if they have a non-full IVC, then fluids are indicated. And that is true. Having said that, ACLS guidelines say everybody with PEA gets 2 liters wide open, just pump them up, okay? So 2 structural causes, and then we need air and ventilation. We need sugar, we need the right amount of potassium, we need fluid, we need temperature, and there's one more yeah but.
Hydrogen ions.
Hydrogen ions, that's how, when I said you have to do gymnastics to make it an H, right? That's called acidosis in medicine, right? So yes, so I've got the 4 metabolic causes, which are really 5. So airway causes being 2, right? Sugar, volume, and potassium. Okay, those are the 4 things I need to live for sure. And then there are what I call 2 yeah buts. One of them is temperature, and one of them is hydrogen ions. And I'll tell you why they're yeah buts. So, I'm going to tell you, every dead person is cold. All of them. So you have to decide, are they cold because they're dead, or are they dead because they're cold, right? So the person found in their 80-degree elderly care apartment is not dead because they're cold. They're cold because they're dead. You don't need to worry about hypothermia as a reversible cause of PEA in that person. So temperature is super, super important, but you know who you need to worry about it in. They're found in the snowbank or the kiddie pond or their bathtub full of ice, or you know who those people are. It comes in, it's part of the history, right? Where were they picked up? So yes, it's important, and yes, you're not dead until you're warm and dead, but that comes in as a presenting complaint. Okay, so hydrogen ions, acidosis. Every dead person acidotic. You can't be dead without being acidotic, right? So you need to decide, are they acidotic because they're dead, or are they dead because they're acidotic? And that's why I call these two yeah buts. Yes, it's true that acidosis can cause PEA and kill you. Yes, it's true that temperature can cause PEA and kill you. But how do we fix acidosis in any timely fashion? Like, what causes acidosis? What things do we see that cause acidosis? DKA, okay. Any of you treated DKA? Some people said yes. How long does it take to reverse that acidosis when you treat DKA?
Couple days.
Couple days? Okay, you're going to code this person for a couple days?
No.
No, right? So if you're dead from acidosis from DKA, you're dead, right? It's not really, that acidosis is not reversible in a timely enough fashion to fix the situation. Sepsis, people get acidotic from sepsis. How long does it take to treat sepsis? Days, right? You're not going to turn them around anytime super soon. You can be acidotic from respiratory causes, right? From hypoventilation, but we've dealt with that, right? You can be acidotic from volume issues. We've dealt with that. So we've got the volume and the airway causes of acidosis that we've dealt with. Some of the sort of systemic disease causes of acidosis, I really can't fix. I mean, I can fix them, but not in this time frame. So really the people that the acidosis is important in is in toxicologic emergencies, where much of it isn't really even about treating the acidosis. It's about shifting the free form of the drug, and alkalinizing the urine for increased elimination. But you're not really making urine when you're dead.
Right.
But things like TCA overdoses, tricyclic overdoses, bicarb, treating with bicarb is really super important. Aspirin overdoses, things like that. But I'm going to tell you that if you give an amp of bicarb, it changes the pH in the bloodstream for about 1.5 to 2 minutes. Not all that helpful. If you hang a drip, your kidneys just adjust and it doesn't work at all after the initial 1.5 to 2 minutes. So our bodies are really smart in not being able to be tricked in their acid, in their acid base thing. So 2 structural causes, 4 or 5 depending on whether you're a lumper or a splitter. What do I need to live causes, and 2 yeah buts. Those are the causes, the reversible causes of PEA. And those are the things you need to think about and remember. So, the only thing we do for PEA is give atropine. Because atropine, what you did as far as atropine goes is the right treatment for symptomatic bradycardia. I feel lightheaded and dizzy, and my heart rate is something below normal. Yeah, atropine's the right thing. Speeds up the heart. The dose of atropine is actually 0.5 milligram at a time for symptomatic bradycardia. This is packaged in 1 milligram, left over from the days when atropine was on the asystole algorithm. So the 1 milligram was the dead person dose. So the 0.5 milligram is the live person dose. So asystole, do we need to speed up in the heart in asystole? Yeah, that would be a good thing. Anything's better than nothing. But as it turns out, atropine didn't really work, and they took it off the algorithm. Now, why they didn't take epi off the algorithm, since that doesn't really work either, I don't know. But anyway, so for symptomatic bradycardia, the treatment is atropine, 0.5 milligram at a time, ad nauseum, or pacing, or both. So we kind of did 2 algorithms in one with that, in that we did PEA and symptomatic bradycardia. Yeah? So for the PEA, the only drug for PEA is epi, milligram at a time, and immediately start thinking about what are the reversible causes. 2 structural causes, however many you want to count, whether you're a lumper or a splitter: airway, sugar, potassium, fluids, and then temperature and acidosis. And airway, we know, is oxygenation and ventilation. So the success of treatment in PEA is going to depend on whether or not the PEA is caused by one of those reversible causes. Question about PEA.
Kind of have a question about symptomatic bradycardia. Is that person always alive?
In order to be symptomatic, you have to complain of something.
Okay.
A dead person with bradycardia is called
Someone in PEA?
right.
Okay. So, but if they have a pulse but they're not responsive and they're showing bradycardia.
So that's different than dead. If
Yeah.
they're alive, unresponsive, bradycardic, yeah, that would be incredibly symptomatic bradycardia. My guess would be that their unresponsiveness goes beyond the bradycardia, because usually if you're bradycardic and symptomatic with it, you're confused, you're lethargic, you're dizzy, but not completely unresponsive. And your blood pressure would have to be so low that you're not perfusing, both reticular activating, right? I mean, the only way to be unconscious is to hit both reticular activating systems at the same time. You know this? Yeah. Sound familiar?
Yeah.
So you'd have to be hypoperfusing your brain just profoundly. And usually, people, even with a blood pressure of 60, are still able to mumble and interact with you. So no pulse, bradycardia, not called bradycardia, called PEA. Okay? Pulse, bradycardia, symptomatic, yes, symptomatic bradycardia.
You have someone in PEA and you suspect cardiac tamponade. How do you do a pericardiocentesis at the same time that you're trying to do chest compressions?
You hold chest compression.
And it takes like a couple of minutes. And, okay. Oh, it's a scary call to make.
They're dead.
Yeah.
Right.
I mean,
One of my attendings said, "You can't make dead worse."
Yeah,
I was like, "Oh, that's
you
a really
actually
nice thing
can
to
make
remember."
dead worse. You can make dead a
great.
lot worse by bringing them back to life with no brain. Right? I mean, I guess that's a morality, ethical issue. But if you ask me, I'd make me dead before make me a vegetable in the hospital for the rest of my life. That's my own thing. But I feel like there are things worse than death, and we as providers are really good at helping those things happen. But I guess different people can have different views on that. But these should be the least scary patients you ever have, right? The patient that comes in dead, what can you do wrong? The person who should scare the living daylights out of you is the 2-year-old running around the room, tearing the place up with a fever, right? That kid should scare you to death, because every now and then, once or twice in your career, that kid's going to have meningitis and be dead the next day. And you're going to have missed it if you didn't pick it up. So those are the scary ones, not the dead is dead. Okay, so we've done PEA. Any questions about PEA or symptomatic bradycardia? No. Okay, let's do one more. This is Mrs. Jones, and she comes in complaining of palpitations.
That's it?
Yep.
Hi, Mrs. Jones. Can
Yes.
you hear me? What's going on today?
Well, my heart is just pounding and pounding.
Your heart is pounding? Or do you feel short of breath?
No.
Any other complaints? Chest pain?
No, I feel good otherwise.
You feel good otherwise? Do you have any medication allergies?
No.
No medication allergies? Okay. Because I'm gonna check her pulse. I think she's in supraventricular tachycardia.
Yeah, I've got a pulse.
So we can start with amiodarone.
Second drawer down.
One. we're gonna give you some medications. Your heart is going a little fast.
How much amiodarone do you want?
Just 150, one bottle.
50.
Your heart is going a little fast, and you don't have any complaints, and you're not allergic to amiodarone, correct?
I've never heard of amiodarone.
Okay. So we'll give you some of that and see how it helps you.
Okay. Didn't do anything.
Can I get another dose of amiodarone, please?
Another dose of amiodarone.
Yes.
Nothing.
Do you feel any shortness of breath or anything right now?
No, I still
chest
feel
pain?
good.
Yeah, let us know if you feel any new complaints.
Okay.
If amiodarone didn't help, then we can move on to maybe some lidocaine.
Sure.
Top drawer.
One and
Okay.
one.
That didn't do anything.
I think. What about try some procainamide.
Okay, you're gonna have to just
Oh.
grab any old bottle.
Yeah.
Okay, and that didn't do anything.
I think the medications are not working, so we're gonna try to do some cardioversion.
What's cardioversion?
We're gonna deliver some electrical shocks to your heart and see if we can help it with that.
Goodness gracious, that sounds scary.
I know it sounds really scary, but we will give you some medications to help you relax, and you won't feel any of it.
Oh, okay. Well, that sounds better.
Okay.
Okay.
So some sedatives,
Okay.
sedation, and we can.
So she's asleep.
Yeah, if you can please charge it to 200 synchronized.
Okay, synchronized.
Uh,
Charging. Here.
Okay. She's asleep. Okay, good. Let's call the scenario. People who have supraventricular tachycardia, what needs to happen in order to reset that situation?
Diltiazem, you can just.
Okay, you can try diltiazem. Yep. So what is diltiazem? Where does diltiazem?
A nodal block.
A nodal blockade, right? We need to block the node and let things sort of reset themselves, right? Or shock them, right? So you did I think she's stable, right? I think you thought you asked the question, sounded like she was stable. You alerted her that you needed her to let you know if she had any other symptoms, et cetera, et cetera. So shocking wasn't indicated to begin with because she was stable, right? So you have medications. So you did list diltiazem as a medication you can use. What else?
Adenosine.
Adenosine, right. So there is an A drug that is the first line drug for SVT called adenosine. Adenosine is an AV nodal blocker. Comes in a little bottle with 6 milligrams. You have 6 milligrams. If that doesn't work, you give 12 milligrams, 2 bottles, 1 bottle, then 2 bottles. It is active in the bloodstream for about 30 to 45 seconds from the time it hits the bloodstream till the time it degrades. So in that time period, it has to get to the heart, act on the AV node, and do its thing. Okay? So it has to be pushed really rapidly and followed with a flush of saline really rapidly. So you got 2 needles and 2 syringes hooked up to the thing. Boom, boom. Okay? Really fast. When we give adenosine, can you adenosinize her? That happens. The patient starts going, oh my God, oh, what's going on? This feels terrible. I feel like I'm going to die. And then things pick up before they actually pass out.
Okay.
Yeah, seriously, that's what happens. So it is a total blockade at the AV node. If the patient happens to be an AFib and you just misdiagnosed it as SVT, what you'll see when you block them down is all these little atrial waves in that blockade with no QRS complexes. You'll see all these little P waves with no QRS complexes, and then you go, oops, made a mistake, I'll treat AFib. Okay, no biggie, except you made the patient uncomfortable for a few seconds. If it's SVT, usually it will get better. You will block it down, and then they will come out and be in sinus rhythm. Adenosine is a huge, huge, huge thing because it is so rapid. It works so well and so fast that it kind of, to me, ACLS will still want you to shock unstable SVT first. That's what they'll tell you. But I am willing to guarantee, almost guarantee, that I can fix somebody's unstable SVT faster with adenosine than I can by sedating them and shocking them. And the goal of shocking unstable rhythms is that you're trying to get them out of that rhythm as fast as possible. So I've shocked SVT once, I think, in my life because adenosine works so well, and I don't believe that, I don't, first of all, there's very little unstable SVT. Most people tolerate it really well. And second of all, I choose in my recipe to deviate from the shock all unstable rhythms recipe. But ACLS will tell you all unstable rhythms should be shocked. But adenosine would be the first line treatment for SVT, for stable SVT, 6 milligrams, then 12 milligrams. If that doesn't work, you can try diltiazem, you can try beta blockers, other AV nodal blockers. Because the atrium does care what happens in the node, right? It is the traffic jam on the way to work in front of you. It cares, it needs to call the attending, right? So those would be the things to use in SVTs. As opposed to the ALPS drugs, which we're not in the Alps, so we don't use the ALPS drugs. Yeah?
Have you ever moved on to cardioversion of those?
Yeah. So if everything doesn't work, then you go to cardioversion. Or if they become unstable and you've tried adenosine, because calcium channel blockers and beta blockers are going to take time. The only thing about adenosine that's so amazing is, like, literally in the time it takes to push the drug, you fix them. The other things you can try if they're stable is vagal maneuvers, right? So I would be very cautious about carotid massage, especially in elderly people. I think the risks outweigh the benefits, but you can have them bear down. There's something called a modified Valsalva, wherein you take their feet, you put them in Trendelenburg, you take their feet and you hold their feet up here and then have them bear down. That's supposed to be very effective. It just came into, like, vogue since I've been not working, but so I haven't tried it, but according to all the blogs and whatever they are, podcasts, it works quite well. And obviously is risk-free if the patient is stable. I usually warn people that I'm going to give adenosine to because they know that something's bad is going on. I usually say, I'm going to give you a medicine to slow down your heart. I don't say to stop your heart, although that is what I mean. I'm going to give you a medicine to slow down your heart. Most people really don't like the way the medicine feels. It feels very scary, like something really bad is about to happen, or that they're being kicked in the chest, or something really unpleasant. It only lasts for a few seconds, and we're right here with you. So I foreshadow what is going to happen, and then we push the drug, I watch the monitor. And the second I see them start to block down, I start narrating their experience. So then I say, bad feeling, bad feeling, bad feeling, bad feeling, bad feeling, bad feeling, bad feeling getting better. Because I think that if you just foreshadow, then when they're in the bad feeling, they're pretty sure that their bad feeling is way worse than the thing you were talking about. Whereas if you foreshadow it and then you're like, yep, this is exactly this is it. Yeah, this is what we're talking about. Right here with you, this is it. That people feel a little less frightened. That's how I do it. You can do it any way you want. But, okay, so in the interest of time, if the patient had unstable AFib, what would you do? Cardiovert, right? Oh, the other thing with cardioverting, this rhythm, you chose 200 joules. Yeah. So the atria cardioverts with a lower amount of joules than the ventricle, somewhere between 100 and 200, classically. Because it's thinner walled, smaller, it's actually made to conduct electricity cell to cell, as opposed to the specialized conducting system. So 100 to 200 joules, similar to last time. The best guess of how much you're going to need is based on body habitus. And by all means, if you need to cardiovert somebody in an atrial rhythm and you're at 200 joules and they don't cardiovert, keep going up. Like, don't say, oh, the atrial cardiovert's at 200 joules, that's the max I can use. You use what you need to use, you know, to get the job done. But you might think about starting at a lower dose, or you might say, I want to start at 200, and that's fine. Okay, so you would cardiovert unstable AFib. What if they've been in it for quite a while?
Then you can't because there might be a clot.
But what about if they're unstable?
If they're unstable, you shock them into it.
If they're unstable, you shock them in. Exactly. So I would say that there is some more nuance to what it means to be unstable in long-standing AFib. Because you're weighing the benefits and risks, right? So if the person has a blood pressure of 70, you're going to shock them. But if they're sitting there, they're going 180 beats a minute, they're 85 years old in AFib, and they're having a little bit of chest pain, maybe if I just get them down to 100 beats a minute or 80 beats a minute, they won't be having chest pain because they're not running a marathon, right? So you might want to be a little bit more interpretive about what it means to be unstable in a long-standing AFib, because, you know, the consequences can be not insignificant with stroke. Stable, long-standing AFib, what do? Anticoagulate, but that does not help
Rate
the fact
control.
that rate control, right. The reason they're here right now is because their heart rate's going 106, 70 beats a minute, right, usually. So rate control, yes, and that rate control can be with a calcium channel blocker, it can be with a beta blocker, but rate control. If they happen to convert after you rate control them and have a stroke, that is not your fault, okay? All you did was rate control. You had no impact on them converting. If they are new onset within 24 hours, 36 hours, whatever you want to call that cutoff, and they come in with AFib, stable, cardiovert. You can either electrically cardiovert them or you can chemically cardiovert them. If you electrically cardiovert them, you put them to sleep, you shock them, and out the door they go 20 minutes later. If you chemically cardiovert them, usually they need to be admitted to the hospital and get, you know, it's a bigger deal. So, so that, my friends, is all of ACLS. I'm serious. That's all of it. That's every algorithm that there is. I mean, you know, we didn't do heart blocks and things like that, but heart blocks are just slow. You know, they need a pacer, right? But that is all the stuff that is in ACLS. And you knew it all. It's just a matter of like standing back and saying, are they dead or alive? Recognizing the rhythm. Is it wide? Is it narrow? Is it regular? Is it irregular? If you see the Alps, ski the Alps. If you don't see the Alps, don't ski the Alps. Shock out of rhythms, not into rhythms. Can't pace a steak. I think that's all I taught you. So, that's ACLS. Questions?